He's the interim chief of the UCSD Division of Gastroenterology. He's a clinical services chief at UCSD, and he's the chief experience officer for UC San Diego Health, which I think qualifies you to improve the patient experience in the endoscopy unit. So also a former UCLA GI fellow. So please welcome Dr. Savides.
Well, thanks everybody. Thanks Vanessa for a great talk. There's lots of questions I have after that. Just a couple things. Lynn Chang was wonderful. Many of us in the room were fellows together at the same time 30 years ago. And so, she's so deserving. So again, it's wonderful to see her celebrated. On a sad note, there was another one of our fellows and junior faculty at that time who passed away this week. Stuart Sherman passed away, and he had been at UCLA for fellowship. Then he went to Indiana and really was one of the pioneers of ERCP, worked with Glenn Lehman and Rob Hawes, came back to UCLA, started really what is the modern ERCP unit and interventional endoscopy unit that we have at UCLA, and then was back in Indiana, and he'd been struggling with illness for a long time. So we're sad to hear him pass, and grateful to Eric and UCLA for putting out announcements about him. So he's really a wonderful person. So with that, I'm going to jump in, as I know he would want us to do, and just keep on forging away at advanced endoscopy. And the other thing I want to say is, for those of you who were here yesterday at LA Live, it was great. The endoscopy that you get to watch from the different centers yesterday, it was from USC and from Cedars, is amazing. I'm hoping, again, in the future, there'll be things like this in one way or another, but it's a great way to see some of these techniques that we're talking about today. So I have no disclosures. These are going to be the different areas that we're going to be talking about today. So one of the things I want to talk about is PSC and cholangiocarcinoma. These are challenging for all of us to really come up with a diagnosis. Is there a cancer in that stricture? Is there not? And we do MRIs, we do EUSs, we do ERCPs, we do brushings, we do biopsies. It's still challenging. The Mayo group is pushed doing FISH, fluorescent immuno in situ hybridization studies. We haven't done it, hasn't really caught on. But one thing we do know is that there's a lot more molecular genetics and diagnostic molecular profiling going on in oncology. And so this group looked at next-gen sequencing for looking at these bile duct strictures. And what they took was at ERCP or at surgery, they took brushings and or biopsies and looked at just our typical current pathology, cytopathology way of looking at things versus adding in next-gen sequencing. And what you can see is that next-gen sequencing really improved the sensitivity in these people. I'm only dropping the specificity a little bit, and such that in PSC patients especially, you're up to 84% sensitivity and a 34% versus a 30% for path or cyto. And so this is exciting in that it may start opening up a better way for us to be doing some diagnosis of these challenging strictures in these PSC patients who we all struggle with. Another thing which has nothing to do with endoscopy, but I think it's kind of cool, is that we all do a lot of wishing that we could dissolve gallstones, and we give lots of ursodeoxycholic acid for a variety of things. Whether or not it works or not is always, I'm not sure, but we do it in stents to try to keep them from getting occluded, and sometimes in high-risk people with stones. And one of the things in the literature you're seeing, at least in animal studies, is that omega-3 polyunsaturated fatty acids really seem to dissolve cholesterol stones in mice. And so this is the first study that I'm aware of that was including this plus ursodeoxycholic acid to dissolve cholesterol stones. And these were small stones, less than 15 millimeters, and it's a small study, involving about 50 patients. But the thing which was impressive is nearly half of the patients had stone dissolution rates compared to only 10% with the ursodeoxycholic acid. And so I'm happy to see that we're getting some more studies looking at different ways that we can do oral medication for gallstones, because I'm going to talk later in the talk about endoscopic ways to manage gallstones, but there may be some other ways coming up, with this drug and some of the others. Oops. Now I'm going to switch over to the convergence. A lot of what I'm talking about here today is ERCP and EUS, and really what we're seeing in the last couple of years is a convergence of both of these technologies, modalities, together. And so this is because of the advent of lumen-opposing stents. And just want to say these are FDA approved for drainage of pancreatic fluid collections, transgastric, transduodenal. This is the on-label indication for these devices. However, they're being used increasingly in off-label uses to address issues in the biliary system, as well as in other enteral anastomoses, and that's what we're going to talk about. So most of this will be off-label indications. Roux-en-Y gastric bypasses are common, and maybe getting a little less common now, but still we see a lot of people have had these, and when they have stones in their common bile duct, we're all faced with the dilemma of how are we going to reach the ampulla to get to that stone. And we know, with the big problem being that because of the small gastric remnant and the long limb, that it's very hard to get to the ampulla. And we've tried using push endoscopy, single balloon, double balloon endoscopes. Sometimes they get there, usually they don't, and it's always painful. Then we switched over to intraoperative procedures where we would have our surgeons put a trocar through the skin into the stomach so we could do a direct ERCP that way, but it required a surgery and you couldn't always get a surgeon who would do that. And more recently, with the advent of the lumen-opposing stents, we're now doing what's called an edge procedure, in which it's an endoscopic way in which we can actually get entry into the bypass stomach, either through the gastric pouch, we can see here, through the gastric pouch, or through the jejunal limb. So this has really changed our approach to doing these. And this is really what we're seeing here is on the left, you can see a picture. It's an EUS scope. It's punctured through the gastric pouch into the bypass stomach, and then you release a double-flanged lumen-opposing stent. And then after you do this, you can then put a scope through that and then go down to the ampulla and do the work. Now, it looks so easy. The problem is that this is somewhat of an unstable anastomosis, and so there's the risk that you're going to lose your stent, and you can then have a separation or dehiscence here, which can be, cause problems, can require surgeries, other things. And as we do this, a number of people have been pioneers in this, have worked out some of the kinks, and we know different ways to minimize this, but it's still, the current teaching is often you put these in and then you wait a week or two, let them mature so that you're going to have a better chance of success and it's not going to fall out, and then have them come back and do your procedure. But that means delaying people perhaps in the hospital, other places. So now we're looking at, can you do it all in the single session? And the single session, either just put in the stent and do it, or do it by suturing in the stent. So, and this is what it looks like when you do these procedures, and it's really a combination of EUS and ERCP together. So this was a study that looked at the long-term safety and efficacy of this, and this was coming out of Amy Tyberg and Michelle Cahala. And they want to see if it's a retrospective series of centers that were doing single step edge. So the ERCP was done at the same time. And it turns out about half of the places would suture in their stent and half the places would not suture it in. And they wanted to see what was the difference in outcome with this. And what they found is if you did not suture it in place, about 12% of the time there was some separation or potentially dehiscence or migration of the stent, versus 4% if you did suture it. So at least on the retrospective, significantly better. And so, their thought was, this is, doing the suturing is going to help you out during edge. I think the key thing to know, and the reason I present this, is edge is becoming more and more common now. It's being done in community hospitals. I think, most people now who are doing a lot of interventional EUS and a lot of interventional RCP will be doing this. But we still debate it at national meetings. We're going to debate. Some people say, no, wait a week or two, it's safer. Others will say, just jump right in. And then there's also some other technical things going on. There's data showing that a 20 millimeter lambs, which is 20 millimeter diameter, is probably safer than for single session than a 15 millimeter. And if you balloon dilate the lambs during the first session to kind of help set it in, probably a decreased rate of migration. So we're still working it out. And I don't want people to think this is just super easy chip shot. Whenever you do it, you get kind of nervous. But it's definitely, we're working out some of the bugs here. We also had the group from CPMC, Ken Binmore and his colleagues, looked at kind of the history of what they were doing. So they looked at doing EA, which is the enterography-assisted ERCPs with single balloon, double balloon. Then the EUSI is where you can do a transgastric EUS into the left intrahepatic duct and then get access that way, or doing EDGE. And what they found is that at the end of the day, they all can work. It's each patient's a little bit different, but EDGE tended to be much more successful, the most successful in all of these. Usually about 90% plus success rate. And that if you try to do the double balloon approach, it's going to take a lot of time. You're going to be less successful, and but it does have fewer complications. So most of us really are trying not to do double balloon or single balloon for these. Now, switching over to another place that we can use these lumen opposing stents is, what if you try to do an ERCP and it's blocked because you can't get in, the tumor is challenging, there's duodenal obstruction. What do we typically do is we typically send people to IR, and they're very good at doing getting drainage. And in our center, we send a lot of people to IR just because we're busy and we just we know they can get it done. However, what we're seeing more and more now is the ability to do the same lumen opposing stent and go between the duodenum or the stomach into the dilated bile duct and then create a fistula that way. And so what this study was looking at here is looking at doing these lumen opposing stents and into the bile duct. Usually it's could be transduodenally, and with or without a double pigtail stent. And so the reason that you would think a double pigtail stent is theoretically a couple reasons. One is you have it in there, it keeps it open even if the stent migrated or moved, which doesn't usually happen. But the other thing is that the bile duct, once it gets decompressed, it's pretty small and thin, and so it can close off or occlude the stent once on the back wall of the bile duct. So if you have a pigtail stent in there, it keeps it open, so you might have greater patency. So that's what they want to look at. They put in the they put in the lambs, and then you can see on the bottom right picture there is what a double pigtail looks like. It's a short 3 centimeter, 7 French double pigtail. And so the most important thing here is in terms of the RBO, which is recurrent biliary obstruction, was significantly lower, 12% versus 32% in this study. So it definitely did seem to decrease that recurrent biliary obstruction. However, there did seem to be more complications with this, in terms of the double pigtail stents, possibly because you're doing more manipulation, pushing away. It's not totally clear. And they use kind of a standard size, a 6x8 or an 8x8 is what they were using. And now there's some smaller ones that might be used as well. But the real kind of key thing here, and the reason I want to bring it up, is this is now becoming an increasingly attractive alternative to doing PTC on these patients. And and it may right now it's not being used as first-line therapy, but you'd almost imagine in the future that someone might go to this as first-line therapy for some reasons. But it's still, we have to figure out some of the adverse event parts with the double balloon, and whether or not we just need to find a different size for the lumen opposing stent or some other way to do it. But it's here, and I think it's going to stay. Now, the one which is probably going to I really want to have on your radar as having the most interest, because I wouldn't be surprised if from FDA approval, this is the next one to come, is going to be for acute cholecystitis. So we see a lot of acute cholecystitis in the hospital coming in every day. And usually, we ask the surgeons to see them. They usually say they're too sick, and they say get an IR to drain them, and that's pretty standard. But you can see from this image here, the gallbladder just lays right on top of the duodenum, and often when it's inflamed, it's stuck to the duodenum or stuck to the antrum. So in a sense, you have a very similar scenario as you do for a pancreatic fluid collection or pancreatic pseudocyst or pancreatic necrosis. It really is kind of already sealed together, and so it's potentially a nice target. And so you can see here, there's really, if you're going to do non-surgical management of acute cholecystitis, there's 3 options that are commonly done. One's percutaneous drainage, tried and true, gold standard. It works great, but then the patients have a drain and all the inherent problems associated with that. Then there's doing an ERCP, and if you can get a wire through the cystic duct into the gallbladder and then leave a double pigtail stent, you can do that. It can work. It's a little bit challenging, to be perfectly honest, and a lot of times these people are pretty sick too, which is why we go to percutaneous. And then the third way is endoscopic ultrasound guided common bile duct drainage and putting in a lumen opposing stent directly in. And so with this study this was a randomized study in looking at the transpapillary gallbladder stenting versus an EUS guided drainage in people with acute calculous cholecystitis, high surgical risk, and looked at it for 18 months in terms of follow-up. And again, randomized, not a big study, but at least it's, we're starting to get some randomized studies with this, 20 people in each arm, looking at both of those two different endoscopic options. And so what we find is that from a technical success point of view, as I said, it makes sense that EUS guided it was always successful, a little bit harder for the ERCP one. The clinical success, once you get something in, they're both working. It doesn't take tons of time, it's like 30, 40 minutes is kind of the typical time frame for these. The adverse events are similar, and most of them are minor adverse events, less than 20% for this. And then the recurrent cholecystitis, and this is important, is that this is at 18 months, you're having a less than 10% recurrent cholecystitis with either one of these modalities. So once you treat them, these are really sick people who generally are not going to surgery anyways, although there were some other abstracts at DDW showing that if they were to go to surgery, you're okay, even if there was a LAMS in there. And so again, the conclusions are that, these are now kind of viable. Both are good options. Probably the EUS guided is going to be a little bit, may have a little bit of advantages for the reasons I outlined. There's also several other studies looking at comparing lumen-opposing stents, versus these transpapillary versus PTC, and suggesting that the endoscopic, drainage method really is an effective and probably safer alternative, even compared to percutaneous drainage that we typically do. And so one of the things I want to bring to your attention is this is a 2023, this past year, AGA CPU, what they call clinical practice updates. And these are where experts will weigh in and kind of what they think is the direction that we should go on for certain disease states and management. And so it is expert opinion based on data. And what this is saying is that for acute cholecystitis, it's saying that really, if you have no perforation of the gallbladder, because that's a relative contraindication doing this, no perforation, and if they're okay to get anesthesia, doing endoscopic approach is a reasonable approach to do. And depending on what the scenario is, ascites, no ascites, duodenal obstruction, no duodenal obstruction, you can kind of figure out which way to go between doing the ERCP route versus the EUS guided route. But I think that you're going to see more and more data coming up, and more of your hospitals starting to do this in terms of a first-line therapy. Now, the barriers are going to be your surgeons and your interventional radiologists, because this is really a paradigm shift for how we approach these patients. But I think it's coming, and I think it's, as we get more data, and especially if there's an FDA approval in the future, I think that will change things. Oops. Okay. Now we'll keep on the theme of putting these lumen-opposing stents everywhere. And so the other thing for those of us who deal a lot with cancer patients is that our pancreatic cancer patients, yes, they get their biliary obstruction, they need to get a bile-duct stent. Then that bile-duct stent blocks off the cystic ducts. If they get cholecystitis, they got to get their gallbladder drained. And then they keep on living, and then they get duodenal obstruction, and then you deal with that. And so we've been, for the last couple of decades, we've been putting in duodenal stents. And I always thought that they were super effective, and I still think they're very effective, and they're still for us, they're still first-line therapy. But what we're finding is that, especially with newer therapies, immunotherapies, other things, people are living longer, and so now they're it's kind of like what happens with the biliary stents. They start outliving the stent, and so then the stent becomes a problem. It gets occluded, and then you say, what do you do? And so our options are the middle slide here. You can see it's a surgical gastro J. But the problem is that by this point, often they have metastatic disease. There's ascites. There's all sorts of reasons you'd rather not do it. Plus, if you do surgery, you may not be able to give them therapy for a period. And so then enter in lumen-opposing stents, going between the stomach and the jejunal limb. And you can see that often, when you have the obstruction, the ligament detritus is right there next to the stomach. So again, it's a target you can have. Now, the one difference, though, in all these other things I've been saying is this is a target which is not distended. It's kind of like when you're doing an edge, the stomach's not distended. So there's some tricks that we do to distend it, either with fluid or with balloons. In this case, this is from Anthony Teo in Hong Kong. What he does is they use a kind of a double balloon device catheter that isolates, two balloons isolate around the ligament of trites, and you fill water up in between the balloons to distend it. What most of us do now is just fill it up with, we just hook it up to a water pump and we just pour lots of water into the duodenum, jejunum, and it fills up. But what they did is they looked and they compared, and this again, the folks in, Anthony and his colleagues in Hong Kong do a really good job with randomized studies, randomized them to an endoscope, an EUS GJ versus a duodenal stent. And the data here is just mostly, I'll show you the highlight in a second here, but mostly it's people's stomach cancer, which is a little different than our usual distal stomach, and then pancreatic head cancers. But what we see in terms of the main take home here is that the reintervention rate, during the course of this, this year's study, is that 29% of duodenal stent patients had to get some sort of reintervention, and the patency rate for the duodenal stents at 6 months was 70%, which is okay, but for the lumen opposing stents was nearly 100%. The other thing the data is looking at, didn't quite reach statistical significance, was that patients were able to eat sooner with the EUS guided ones as opposed to the duodenal stents, which need to open up a little more. So again, this is another area that we're starting to see these lumen opposing stents change what we do, kind of a convergence of a lot of different interventional techniques. But again, it is technically challenging too, and it's not, without its risk. There's going to be at least a 10% risk of complications, some of which can be major. So I don't want you to think it's going to be just a simple thing. Finally, EUS guided liver biopsies. Now, this is a simple thing. I want everybody in this room doing this procedure, and I'm actually not kidding. So, this is an easy thing for people to do, and it's the easiest thing for us to do. And this is Dave Deal, who was actually here at UCLA when Stu Sherman and I and Win Chang were here. Now he's over at Geisinger in Penn. He's been really the person spearheading EUS guided liver biopsies in the US. And here he looked at 19 versus 22 gauge needles and showed that if you use a 19 gauge needle, you get a longer specimen and better, more adequacy. The reason that I bring that up is that, it's definitely better. He didn't really describe the quality. And when you look at, there was another group coming out of UAB, which actually did compare the quality to percutaneous liver biopsies compared to transjugular. And at least in their hands, it wasn't as good. It didn't perform as well as either percutaneous or transjugular. But there's, they didn't really go into the technical details, which Dave was talking about in terms of the needle size, the techniques used, and some of the other things. But I think that this is another one of those techniques that are here to stay. But I personally believe that this should be done by hepatologists. So if you're a hepatologist, we're starting to train our hepatologists. Vanessa's looking at me like, what are you talking about? But we're going to start training, because it's just like for lung cancer. We started doing EUS for mediastinal nodes. Yeah, people did it for lung cancer. Once we trained the pulmonologists to do it, that's all they do all day long. Everybody uses the technique. For liver biopsies, our liver folks are, I'm not sure it's doing anything, but I think that if they were actually involved in it, they might. So we'll see where it goes, but you'll see it's definitely a viable option. Where it goes, we'll see. So this is the end. And again, as Lynn says, it's great training fellows, and this is our fellows, our advanced GI hepatology IBD training group that we had a graduation for a week or two ago. So thank you. And Eric, do you want me to just go right into another? Okay.